I think the main change that we're seeing in mantle cell lymphoma over the last couple of years is the movement of BTK inhibition into the first-line treatment. And we've got now 4 randomized trials that have reported in this era. The ones that have really changing practice, I think, are firstly the Triangle study, which I think most of us would agree has set a new standard of care for the first-line treatment of young, fit patients with mantle cell lymphoma. And I think there's 2 major changes. The first is that the addition of ibrutinib in a time-limited fashion to first-line treatment improves failure-free and overall survival. And the second thing is, if you give ibrutinib in this setting, you can drop the autologous transplant for the vast majority of patients. So I think pretty much everyone who's got access to a triangle approach would recommend that as a standard of care approach for these first-line young, fit patients. In older patients, we've got the ECHO study, which has recently reported showing the benefit in terms of progression-free survival of acalabrutinib to bendamustine rituximab, and a trend, importantly, for an overall survival benefit. And I think we do need to see how that pans out in the long run. The third approach is the ENRICH study, which is using a completely chemo-free approach and omitting chemo completely, just using a doublet approach of rituximab plus BTK inhibitor. So I think as physicians, we now have to make these choices for different patients. So I think it's very clear that if you're a young patient, I think most people recommend Triangle. And if you're a patient, say, significantly older than 70 or with other comorbidities, then probably we're going to go for an ECHO or BTK plus rituximab approach. But there's a big group of patients in the middle who potentially could be fit for either a Triangle or an ECHO approach. And I think with those patients, it's largely a decision about whether you consider them fit for high-dose chemotherapy, and then it becomes a discussion as to whether they would like a time-limited treatment or an ongoing treatment with BTK. There may be some patients with less proliferative disease, and I think the ENRICH study and the Nordic group's Altamira study have demonstrated this, that if you have a very low risk disease in terms of low Ki67, absence of P53 and no blastoid disease, these patients may actually do very well with the doublet treatment of simply BTK inhibitor plus rituximab. So I think if I had a patient like that, particularly if they're elderly, I might consider offering them a doublet approach of BTK plus rituximab.